Andy. Great to see so many of you here today, and have a little sunshine spread on our lives by Andy there in terms of the introduction. If that's what the introduction says, imagine what it feels like living through that. And I was just musing on how I might describe what that feels like on the way here, and then I thought, well, actually, I took a decision this morning to get one of those Boris's bikes to drive here. And I know how to ride a bike, and GPs know how to treat patients and think about their needs, and what they're in charge of commission is quite a good thing. So I thought, right, I'll get one of those bikes. I've got a key. I'll give it a go. I sort of know where I'm going. So I learned quite a lot riding here this morning. So I learned that I didn't know how to ride a bike. That some people are quite helpful on the journey that I've had here and didn't want to kill me, but some people were oblivious to my existence and appeared to want to kill me, actually. I didn't quite know where I was going. That I saw things with a completely different and fresh perspective because I went on a slightly circuitous route. When I did end up where I thought I was in the wrong place. But I still managed to get here on time, and it was quite good for me, and I learned a lot. Now I think that if you look at commissioning and the reforms that we've been on, I think that's the journey that some of the organisations have been on, because the system that's being designed to deliver changes in healthcare isn't quite ready to deliver the changes that we require. So as Chief Executive of NHS Confederation, my job is to represent all organisations who commission and provide care, and most providers, most commissioners are members of the Confederation. And I've been in the job for about 3 months, and I took it because as a Trust Chief Executive, what I found was me and my colleagues locally were doing the equivalent of what I've just done on the Boris Bank. We were trying to make it work, but we didn't quite have all the skills, we didn't have quite all the infrastructure. And the system, it felt to me, was getting in the way of what we wanted to achieve. And given the rhetoric about bottom-up and local people being in charge, and you might have seen from the King's Fund this morning that they're talking about local leadership driving change as well, I thought that a representative body, which is the voice of the system, in an environment where the system has to change, seems like a good and powerful way of driving change. So my role and ambition in the Confederation is to try and make that happen. Because what we tend to have with the NHS, particularly in election years, is it becomes a political football. Now last time I looked, public confidence and trust in doctors was about 94%. NHS managers, it was about 44%. Politicians, it was about 20%, and sorry, Andy, journalists, it was about 11%. So if we speak with the new commissioning and provide a landscape with doctors and clinicians and managers together, I think our voice could be incredibly powerful in thinking about reform. So I want to talk a little bit about that. And one of the things that I usually ask audiences is, and I might as well do the experiment with you as well, so who's been working in healthcare for more than 10 years? It's just like the NHS, everyone's been here forever. So 20, 30, 40, I haven't got any 40s, but people who've been working in healthcare for 30 years. As somebody always said that it's tough every year. Yes, I can see you laughing. So somebody always says it's tough in healthcare every year. And I think what that leads us to think is that it's always tough and we always cope. Therefore, we just carry on doing what we're doing. I think at the moment we're in a perfect storm of a context which means we can't do that. We can't do that. And if you just took Andy's graph that shows the scale of the financial challenge, you'll see that we can't carry on doing what we're doing, because my reflection would be all of the changes that we've seen over the last decade or so, maybe the last 2 decades, have been in the way we administer and commission services. What we fundamentally need is a change in the way we deliver care, and that hasn't happened. So we are in this perfect storm. It can be quite gloomy, and there's 3 elements of it. So the first is that we've got an episodic approach to healthcare in this country, and our citizens need ongoing support, because what we have are 18 million people with long-term condition, a growing older population, and 3 million people with 3 chronic conditions or more. Now last time I looked, You can't be cured for being old or having a long-term condition, so we're going to have an ongoing relationship with you. So we have a system that's geared up to deliver episodic care and a set of citizens who need ongoing support and long-term condition management. So we need to change, irrespective of the money. The second thing that's part of the perfect storm is the scandals that we see and the headlines we have every single day, which I think are unimaginable from the kind of thing we had 10 years or so ago. So if you imagine Jennifer's ear, remember the Jennifer's ear story in the election, which caused a massive furore? We seem to have a Jennifer's ear every day at the moment. And the third bit of the perfect storm is the money. And Andy's just showing you the graph around that. Now we could get very gloomy around all of this. And what we talk about often is that's the burning platform we're on as an organisation and as a system. And if you talk to NHS managers, who can be a gloomy and cynical lot, what you find is that they will go into detail about how difficult things are. But I think there's an emerging sense of, we've had enough of that now. We spent 4 years, I think as Andy's just described, 4 years going through some of the biggest system reform ever. So big you can see it from space, and I think Andy's just described NHS England, so big you can see it from space. And some of the toughest financial challenges in the age of austerity ever. But we're still here. Things are creaking, but we're still here. And I think that should give us some confidence. So what we're beginning to see as NHS managers and leaders is a sense of, can we have a burning ambition, please, of where we want to actually get to? I'm absolutely sick and tired of talking about this burning platform role. Because the burning platform doesn't actually make you get to where you want to go, it just gets you away from where you are. So I think there's an emerging consensus that what we need is some vision for the NHS about where it's going, how we're going to tackle that demand that we require, the financial challenge, and give public confidence back to the NHS. Now with our partners, we've been doing some work with the Academy of Medical Royal Colleges, Faculty of Medical Leaders and Management, Foundation Trust Network, Local Government Association and Royal Colleges, and National Voices, patient organisations, to say what's the best evidence about why we need to change and which areas do we need to change in. And this document, half of which is references, so it's irrefutable evidence of the need to change. And we've done this not for the NHS, because they're the middle of the change, but we've done it for the politicians and the public. Because there are still politicians and members of the public who will fight any change that we try and make, even if it delivers better outcomes, savings and better care. In fact, that comes from the DODS research that we've done of MPs and polling of the public. So what this says, and this is part of the NHS voice trying to be heard, is there are 7 areas that we really need to think about changing it, and they follow quite a neat pattern, I think. So first of all, 21st century needs are different. So secondly, we need to change services the way we deliver them fundamentally. Third, that requires leadership. That leadership's in the system, because the system's got to change. And that leadership's got to be value-based, because some of the decisions we've got to take are going to be tough, and people might not like them, but there will be the right decisions. Fourth, that's got to drive new culture, and that culture's got to be about 2 things. It's got to be about staff who feel engaged in their own organisations, because all the evidence is that delivers better outcomes, and services which engage people as co-producers in their own healthcare, because we waste the assets of our patients and carers every single day in the way that we provide care. And I know that some people in the room will be working actively on that kind of agenda. So if we have that leadership and that culture, then the 5th thing we need to do is think about the workforce, because the workforce needs to be different in terms of generalist skills, ability to work across different organisations, and how it works as a team with carers and patients. If we do all of that, then we still won't get to where we want to be unless we really embrace technology. Now Andy gave the classic description of what technology means in healthcare, which is it's a cost driver, because we've got these fantastic things like gamma knives, which means we can do some amazing things to people. I'd also like to see technology as an efficiency driver. You know, if we can get to the point where you can read the human genome, it used to cost $100,000, now it costs $100. And you can read that genome in 47 seconds. Costs keep coming down in technology. Most of our interventions and interactions with patients are low-cost, high-volume ones, but we don't think of technology in that way. And then finally, we need to think about how we spend our money. We need to think about how we spend our money. What's the evidence base that is actually adding value? And how do we allocatively think about the money? So as Andy described, most of the efficiency gains we've done have been technical efficiency gains, so we've done the same thing cheaper. But what we need to do is something different and better, simpler and cheaper. So in that environment, what we're saying as an organisation is the NHS fundamentally needs to change, and people will visibly see that it changes because it needs to meet 21st century needs. If we're going to do that though, there are some asks that we've got of the system. The first is let's have a vision, and we could create a vision and say what it is now, based on, if you read what Reform has said about the NHS, if you read what John Alden's Whole Person Care stuff says about the NHS, if you read Public Health England or Simon Stevens or whoever, it all comes down to a few simple things that are going to be a given for the future. So place-based health, supported self-care, integration of teams around general practice based on a defined population of people who need ongoing support, hospitals which are designed to be the maximum size they can be and still be local and still be sustainable, tertiary centres of excellence where you will survive and have better outcomes, which can also be global centres of research and development, and then 7-day urgent emergency care wrapped around that, based on the idea that you can be treated in the community as well as in a hospital. And I could talk about that a lot, but I won't. Now the second thing we need is some changes, because what's clear is if we know where we are today and we know things fundamentally need to change to deliver a vision of the NHS which looks different, the arrangements we've got now won't work. It's a bit like me on the bike, this bike wobbling around the bus lane, not quite knowing where I'm going, and when I get there all the bike racks are full. You know, we need to change the way that we actually incentivise healthcare, regulate healthcare, manage healthcare, work with patients and the public, think about the evidence base. And the sort of asks that we're starting to think about are, firstly, let's get real then about this localism, hands-off stuff, because it is true that all of the improvements that are being made at a local level are down to the goodwill of leaders at a local level. So what I see in my visits are that people are working together outside their own interest and sometimes against the way they are regulated and performance managed. Because we have a regulatory and performance management system which requires you to deliver for your organisation. But in doing so, what you need to do is deliver for the system, and no one holds you to account for that. So the risk and reward arrangements we've got aren't balanced. So the first thing is we have to get this local leadership thing right. The second is we need to recognise we're in an election year, and that means that nothing will happen until after the election in terms of focus around significant fundamental change, because what we'll have to do in the run-up to the election is focus on 18 weeks, cancer, A&E, financial, ambulance response times, all these hard-fought gains that we've had, which I think is only right. But we need to be ready post-election to make some significant and fundamental changes, and we need a mandate for that. So we're asking politicians to sign up to that. We recognise the political realpolitik, but we need them to sign up to that. So those are some big givens, and then we're asking for some specifics. So you may have seen that local governments asked for a 5-year settlement for social care. I personally support that. I think it's pretty clear that cuts in social care have a knock-on consequence for the support of older people. That has a knock-on consequence for the health service. So we need to think about how we're managing social care. I'd like to have a long-term settlement for the NHS, because fundamental change requires stability. Contracts with people like you, if you're going to take risks, require stability and need to be longer, so you can manage the risk across a longer period. So I'd like a 5 or 10 year settlement for the NHS in real terms. And I'd like us to have some additional resources for 2 years to make sure that we can get over the bumpy ground we're going to have as we manage change. Because if we're going to deliver services very differently, existing providers will have stranded costs. So we're asking for some financial improvements to be made, a new financial regime to be put in place that incentivises long-term condition management. We're also asking for parity of esteem for mental health, and to make that real, because if you are unwell, then your mental health's affected. And if you're mentally unwell, you're much more likely to have a long-term condition or die prematurely. Now, we've got this artificial barrier between mental and physical health, and I'd like to see that end. Commissioning, I think, where one of the big asks for us is to say that we seem to have got into a narrative nationally, you may have seen this, that everything is resolved through the provider and the regulator. So if there's a quality issue, CQC will sort it out. If there's an issue about sustainable organisations, then Monitor and all the TDA and the providers will sort it out. Actually, commissioning, and having Simon Stevens, the International Round Commissioner as head of NHS England, is a good thing. Commissioning is all about transformation. Commissioning is all about allocative efficiency. Commissioning is all about evidence. It's all about the effectiveness of treatments. It's all about clinical leadership, about engagement with patients. I think what we'll see in the next year or two is commissioning come back into play in a major way. And I'd really like to see that done in a way which is joined up. I'll leave it to you to muse on the fact that the Lansley reforms took commissioning and split it up. And then Jeremy Hunt talks about bringing commissioners back together. But what is essential for me is that if you're thinking about commissioning primary care, you need to do that at the same time as community services, mental health, social care, hospital care, and at the moment those are split. And I think NHS England are making moves to bring them back together, which I think is a really good thing. So for you in the room, I think working with commissioners as well as providers is going to be essential over the next few years, because they're the ones with the money and they're the ones who are going to be driving change. And what we want to do as an organisation through NHS Clinical Commissioners is give people the best chance of succeeding in doing that, because they'll have a longer settlement, they'll be able to do longer contracts, they'll be able to work with a variety of providers and partners. And it'd be really good, one of the things we want to do is to set the tone around how the NHS works with the third sector and the private sector. The private sector is part of the social fabric. Last time I looked, it employs people, it delivers services, and the NHS doesn't have a monopoly on values. So having an environment where business between the NHS, medtech, pharma companies, for the benefit of patients and for the benefit of the economy is a good thing, is something that I want us to see. So fundamentally what we're trying to do is say that we know we're in a difficult context, we know we're on this burning platform. Actually we should have a burning ambition for the NHS. To do that requires some asks, and some of those will need to come in to play immediately after the election. For you, what you'll have to navigate, I think, is a bit of a difficult and interesting time, but I would say build your relationships locally as well as nationally. I would say lobby as much as you can around the changes that are required, and recognise the environment that you're going to be in is going to be focused on two things. Defined populations who require ongoing care, children, people with multiple long-term conditions, and older people, and evidence-based, effective technology and treatments which will drive change. Now, all of the things I've just said, I hope come to pass, but they'll only come to pass if we support providers. And I'm going to pass over to Chris to talk about providers, because I think one of the things we often do in the service is fail to recognise that regulators, commissioners, representative bodies don't actually deliver any care at all. The only people who deliver care are providers. So I'm going to hand over to Chris to give us a view of how things feel from the provider sector. Thanks very much.